are going to the last session, hot topics in GI disease. I would like to introduce Professor Nonthalee Pausawasdi as our moderator. Professor Nonthalee Pausawasdi received her MD degree from Thailand and completed her postdoctoral research training in medicine residency, GI fellowship, and advanced endoscopy fellowship training at the University of Michigan, USA. She is an associate professor at the Faculty of Medicine, Cleveland Hospital, Medical University. She is the president of the Thai Association for Gastrointestinal Endoscopy and the program director for the WGO Endoscope Training Program at Sirat Endoscopy Center in Bangkok, Thailand. Now, please join me welcoming Professor Nonthalee Pausawasdi.
Hello, everyone. Thank you so much for having me here today. I want to thank the organizing team for giving me the opportunity to be part of this conference. And it is my pleasure to welcome you all to this last session of the day. And thanks for all of you for sticking around with us. And in this session, I have the pleasure of moderating two of the world-renowned speakers in the field of GI bleeding, NSAIDs, and aspirin. And first of all, I would like to welcome Professor Francis Chan from Hong Kong. Professor Chan is the Dean of the Faculty of Medicine, the Chinese University of Hong Kong. He's the Director of Center for Gut Microbiota Research at CUHK. He's a world-renowned clinician scientist in gastrointestinal diseases. He has published over 840 scientific articles in high-impact international journals. His contributions to medical research have been recognized worldwide with numerous national and international honors and awards. He's the first Chinese and second in Asia to be conferred the International Leadership Award by the American College of Gastroenterology in 2018 to recognize his remarkable achievements and leadership in gastroenterology. Without further ado, please help me welcome Professor Chan to give us a talk today, and his talk is entitled Management of Patients on Anticoagulants and Antiplatelets During Acute GI Bleeding. Please.
Thank you. Thank you, Ms. Chairlady, for a very kind introduction. It's really my privilege to have this opportunity to talk to the audience again. And the topic is really about the management of patients on anticoagulants and antiplatelet drugs during acute GI bleed. And this is my conflict of interest statement. This is where I come from. After 3 years, I'm still with the Chinese University of Hong Kong, and the Prince of Wales Hospital is my teaching hospital in Hong Kong. We all know that with our aging population, antithrombotic agents are now the major cause of GI bleeding worldwide. Probably it may even have surpassed the importance of H. pylori infection in terms of upper GI bleed. And in the last few years, there are guidelines from Europe, from the UK, and even the United States with regard to the use of antithrombotic agents in patients undergoing GI endoscopy, both for elective cases and for emergency bleed. But the trouble is, if you review the US and European guidelines, you realize there are the following problems. There are unmet needs, there are inconsistencies between guidelines, and there are certain doubts about their recommendations. And because of that, in 2018 and 19, with the endorsement by the APAGE and the APSDE, we have published a joint Asia-Pacific guidelines on the management of patients on antithrombotic agents undergoing both emergency and elective endoscopy. And until a few months ago, in fact, the ACG and the Canadian Association of Gastroenterology, the CAG, also jointly published an updated guideline for patients on antithrombotics during acute GI bleed and the perioperative period. However, I would like to share with you that while there are updated guidelines from the ACG and the CAG, if you read it carefully, in my personal biased opinion, you will find there are a lot more don'ts. Don't do this and don't do that. And there's even more uncertainties as to what we should do. So in the next 20 minutes, I would like to share with you, using a number of case scenarios, how we should approach such patients and the discrepancies between our Asia-Pacific versus the updated ACG CAG guideline. Now, the first case is a 65-year-old man who was admitted for fresh hematemesis. He's on warfarin 5 mg daily for atrial fibrillation. Recently, he received levofloxacin for chest infection. On admission, his blood pressure was low, tachycardia, hemoglobin down to 7. The INR was 3.5, super therapeutic. You are consulted for emergency endoscopy on a Friday evening. Bad luck. The question is, number one, is it mandatory or desirable to correct its INR before doing emergency endoscopy? And if yes, which blood products, reversal agents are you going to use? We all know that warfarin has got multiple drug interaction, and antibiotics such as levofloxacin is a common culprit leading to supratherapeutic dose and bleeding risk. And I'm sure we are all aware of quite a number of possible warfarin overdose antidotes, such as transfusion, FFP, vitamin K, and also the right lower corner, this prothrombin complex concentrate, or in short, we call PCC. How should we choose among them? Now, according to our APAGE ASGE guideline in 2018, first of all, we recommend the use of this 4-factor PCC plus low-dose vitamin K, meaning 1 to 2 milligram, only for life-threatening bleed for patients with a supratherapeutic level of INR. We do not recommend delaying endoscopy for life-threatening bleeding until normalization of INR, and definitely rechecking the INR after reversal therapy is not mandatory before emergency endoscopy. Now, if I refer to the latest ACG-CAG guideline, it's kind of interesting in that they, first of all, suggest against the use of FFP. They could not reach a recommendation for or against the use of PCC. But if we are forced to choose between PCC and FFP, they would suggest PCC compared with FFP, and they were against the use of vitamin K. Now, despite all these discrepancies, I want to highlight the fact that we should only consider using these reversal agents for life-threatening bleeding with very supratherapeutic level of INR, and regardless of which product you use, the level of evidence is really low. And importantly, we should not delay emergency endoscopy for patients who are hemodynamically unstable. Now, this patient was found to have a duodenal dilophoid lesion, which was stopped with a hemo spray on a Friday evening. Then the next questions are, number one, when will you resume warfarin? And two, will you start bridging therapy with heparin, knowing that it may take a few days or even more than a week to re-warfarinize your patient? So if I referred to the European guideline published in 2015, they recommended resumption of warfarin between day 7 and day 15. Now that might pose a bit of problem because by delaying resumption of warfarin till day 7 to 15, you may increase the patient's thrombotic risk before full warfarinization. However, if I refer to the latest ACG-CAG guideline, they didn't make any recommendation for acute bleeding. So if I referred to our APAGE, APSDE guideline, actually we recommend resuming warfarin after day 3 for patients with high thrombotic risk. We believe this is a reasonable approach for a number of reasons. First of all, it always takes time to re-warfarinize the patient. And if we resume warfarin earlier, we would minimize the risk of thrombosis and therefore avoid the dilemma and the bleeding risk of using heparin bridging. And therefore, we believe that for such patients, once you are confident that the hemostasis has been achieved, please resume warfarin as early as possible. And we are now using more and more commonly a new class of anticoagulants, the direct oral anticoagulant, DOAC. Now, comparing DOACs with warfarin, the major difference is that DOACs in general have a much shorter half-life than warfarin, and the peak effect will be seen in 2 to 3 hours after an oral dose. Meaning, if you start DOAC, you will see the effect in a few hours, and once you stop DOAC, again, after a few hours, the effect will be gone. And this would have important implications in the management of acute bleeding on patients on DOAC. Now, this is the second case. A 70-year-old lady on dabigatran for non-valvular atrial fibrillation. She had diabetes, hypertension, and impaired left ventricular function. She was kind of thin, 40 kilogram. The serum creatinine level was said to be high normal, and a screening colonoscopy was scheduled in 2 weeks. Now, the first question is, should DOAC be withheld for colonoscopy? And if yes, when should we stop DOAC before colonoscopy? And again, when should we resume DOAC after the procedure if there was no bleeding during colonoscopy? We all understand that certain endoscopic procedures carry high procedural bleeding risk, and colonoscopic polypectomy is one of them. Therefore, we have to consider colonoscopy as a procedure carrying high bleeding risk. And according to our Asia-Pacific guideline, for patients undergoing low-risk elective procedures such as diagnostic upper endoscopy, we don't need to stop DOAC. But for high-risk elective procedures such as colonoscopy, we know the likelihood of polypectomy is high, and therefore we recommend withholding DOAC for at least 48 hours before the procedure. Now, if you refer to the updated ACG-CAG guideline, they simply suggest temporarily interrupting DOAC rather than continuing DOAC. But they didn't really mention how many days before the procedure should we withhold DOAC. Actually, in our Asia-Pacific guideline, we have included a table to guide clinicians as to the number of days before the procedure should we stop DOAC, depending on whether the patient is taking dabigatran or other DOACs. And importantly, we emphasize we should look into the patient's creatinine clearance rather than the serum creatinine level in the timing of discontinuation of DOAC. Like for this lady, she is 70-year-old with a low body weight, and the so-called high normal serum creatinine actually translate into a creatinine clearance of only 45 ml per minute. Now, in this regard, this patient actually should have stopped taking dabigatran for 4 days before colonoscopy, for 4 days. Unfortunately, she was instructed only to stop dabigatran 2 days before colonoscopy because everyone just looked at her serum creatinine as well instead of calculating the creatinine clearance level. During the procedure, there was no immediate bleeding after polypectomy. And the question is, when should we resume dabigatran in this 70-year-old lady? If you refer to our Asia-Pacific guideline, first of all, we don't recommend bridging coagulation with heparin. Number two, we recommend resuming DOAC after adequate hemostasis has achieved because we are well aware of the short half-life of DOAC. With regard to the ACG-CAG guideline, interestingly, they said they could not reach a recommendation for or against resuming DOAC on the same day versus 1 to 7 days after a high-risk procedure. So it's not particularly helpful, unfortunately, with the updated ACG-CAG guideline in this regard. And the story continued. She was discharged on the next day and was instructed to resume her usual morning dose of dabigatran on day 3. On day 4, she was sent back to the casualty department in the afternoon for hypotension and profuse PR bleed. The hemoglobin was down to 6.8, and the clinical diagnosis was delayed post-polypectomy bleeding. Now, the first question we want to ask is, what is the likelihood that this bleeding episode was aggravated by the use of DOAC? Do we need to measure the DOAC level, knowing that measuring DOAC level can be quite complicated, not available in most conventional laboratories? Now, we know from various clinical studies that the following are the risk factors for bleeding with DOAC. They include OH, in particular above 75, renal failure with a creatinine clearance less than 50, advanced liver disease should avoid using rivaroxaban, Concurrent use of the following drugs such as antiplatelet, antifungal, and cancer chemotherapy. As I mentioned earlier, low body weight and surprisingly, female gender are all risk factors for bleeding with dough egg. And for this particular old lady, I believe she did have a high likelihood of toxic level of dough egg, even without measuring the blood level, because the last dose was taken only 9 hours before attending the A&D department. She has renal impairment, old, underweight, and female gender. And according to an Asia Pacific guideline, we recommended that one should consider using activated charcoal if the last dose of dough egg was taken within 3 hours. Unfortunately, the last dose was 9 hours ago, so that may not be all that useful. We also recommend the use of this monoclonal antibody against dabigatran for life-threatening bleed. Now, what about the current ACG-CAG guideline? They basically advise against everything. They said one should not use idarucizumab and for dabigatran, and he also suggests against the use of these antidotes against other dough egg, and they also suggest against the use of PCC because of the risk of thrombosis. So basically, we don't have any good evidence about the use of this antidote against direct oral anticoagulant, but we don't have any good solution to how to tackle these patients with profuse bleeding. So what should we do? For this lady, we at that time didn't have any specific assays for dough egg, and also we didn't have idarucizumab in Hong Kong back then. And this patient showed continuing signs of bleeding. Therefore, we had no choice but to do an emergency colonoscopy. Fortunately, we could identify the site of the post-polypectomy bleeding, and it was controlled with hemostatic clips. And after the post-polypectomy bleeding, she survived this episode, and therefore her dabigatran dose was adjusted downwards according to her body weight and creatinine clearance. So this kind of communication would be very important with our cardiologists. And we resumed dabigatran on day 7 after a clean second look endoscopy to make sure there's no further delayed bleeding. So my third case is a 55-year-old man who was admitted for acute myocardial infarction, who received aspirin and clopidogrel on admission. And within 6 hours, he underwent primary coronary angioplasty, followed by abicizumab infusion for 12 hours. And after 24 hours, he developed fresh metamorphosis, hypotension, and tachycardia again on a Friday evening. Very unfortunate for the endoscopists, I mean. So what can we offer before endoscopy apart from resuscitation? Certainly, with good data now, pre-endoscopy PPI infusion can really downstage the endoscopic bleeding stigmata, and therefore would be a useful non-invasive option while waiting for the experienced endoscopy to come back to do the procedure. So during endoscopy, again, this patient was found to have a bleeding dural lesion, which was controlled with a hemostatic spray. The question is, after successful hemostasis, when should aspirin and or clopidogrel be introduced? Right away, wait for 3 to 5 days, or we should wait until complete ulcer healing? And should one resume one or both antiplatelet drugs? According to a large-scale structured overview from the United States, for all reported cases of late stent thrombosis, it was found that the median time to stent thrombosis was as short as 7 days if both antiplatelet drugs were discontinued. But if you only stop one of the 2 antiplatelet drugs, the median time to thrombosis was up to 3 months. So the important lesson to learn is never stop both drugs. It's kind of dangerous, especially for patients with a coronary stent. So in Hong Kong, quite some time ago, we did this double-blind randomized trial focusing on the best timing of resumption of aspirin among patients who presented with acute upper GI bleed with aspirin. And on the left-hand side is really the proportion of recurrent upper GI bleed. We randomized these patients to resumption of aspirin on day 0 versus resumption of aspirin after waiting for 8 weeks. And we found that if we resume aspirin right away, there is a trend towards increasing incidence of recurrent bleeding within 8 weeks compared to the placebo group. However, those who receive early aspirin resumption, as shown by this dotted line, had a significantly lower all-cause mortality. Most of these mortality are due to cardiovascular mortality. And therefore, our Asia-Pacific guideline recommend that we should withhold aspirin and clopidogrel for up to 3 days, because the first 3 days had the highest risk of recurrent bleeding. And we should resume at least one drug on day 4, knowing that the antiplatelet effect usually lasts for about 5 to 7 days. And definitely we should avoid prolonged discontinuation of both drugs for more than 7 days. If I refer to the latest CAG guideline, they suggest that aspirin should be resumed on the day of hemostasis, especially if endoscopic hemostasis has been secured. So I guess overall speaking, we are quite concerned about recurrent thrombotic risk, whereas the bleeding risk can be well controlled by endoscopy. So this is my last case, a 75-year-old lady on rivaroxaban for chronic atrial fibrillation. She has a history of diabetes and minor stroke. Recently, she was diagnosed with coronary artery disease requiring PCI. After PCI, she was put on dual antiplatelet therapy, and rivaroxaban was resumed. So in other words, she was on triple therapy, an anticoagulant plus dual antiplatelet drugs. She developed acute GI bleed on day 5, and the question is, what has gone wrong with her antithrombotic therapy? Can this be prevented? Now, first of all, if I refer to the latest American College of Cardiology expert consensus, there are a number of rules of thumb that we should all remember. DOAC is preferred to vitamin K antagonists for atrial fibrillation. And number 2, triple therapy, meaning combination of dual antiplatelet therapy plus an anticoagulant, is not recommended due to an unacceptably high risk of bleeding, up to 12% in 1 year. And therefore, actually nowadays, one should really use an oral anticoagulant plus a non-aspirin antiplatelet drug such as P2Y12 combination for the first 6 to 12 months after acute coronary syndrome. And then one should switch from this non-aspirin antiplatelet drug to aspirin from month 7 to month 12 if the PCI is done for stable coronary artery disease in order to minimize the risk of bleeding. Therefore, for this particular patient, I believe, number 1, we should definitely stop this triple antithrombotic therapy. There's really no need to check DOAC level because previously she was on stable dose of rivaroxaban. We probably should avoid using PCC because of the increased risk of coronary thrombosis. A preemptive IV PPI infusion should always be used before emergency endoscopy, and I would recommend resuming antiplatelet drug on day 4 as previously explained. The question is, what about the best timing for resumption of DOAC? It all depends on her risk of coronary thrombosis. And for this patient, given the fact that she's all with all these risk factors, her calculated CHECK2 score, the score for cardiovascular thrombosis, is very high. And therefore, we recommend resumption of DOAC early, meaning before discharge, given the high thrombotic risk and the short half-life of DOAC, and that the recurrent bleeding risk declines rapidly with adequate hemostasis. So my last advice is we should really switch her to a DOAC with a lower bleeding risk. And recently, we've done a population-based study in Hong Kong involving tens of thousands of patients, and we found that, in short, those who receive apixaban had a significantly lower bleeding risk than those receiving warfarin. And among different DOACs, apixaban appeared to have a lower bleeding risk than dabigatran and rivaroxaban. And with that, I would like to thank your attention and look forward to welcoming you to Hong Kong very soon in the near future.
Thank you so much, Professor Chan. I have a lot of questions lining up for you, but I will bring you back at the end of the session to answer all the questions. The next talk will be given by me, and I'm actually going to go over there to give a talk. Oh, this is actually not my talk. Okay, again, I'd like to thank the organizing committee for having me here today. And my talk today is entitled New Trends in Treatment of Upper GI Bleeding. Okay, you can see my slides. The outlines of my talk today, I will cover non-variceal upper GI bleeding. I will talk about the evolving techniques and the current updated data. I will tell you about the pros and cons of the novel techniques in real practice. And I will finish with the tips for managing upper GI bleeding. Just a month ago, I've come across this very interesting article in the Gastroenterology News. And the article is about the increased incidence of upper GI bleeding in the emergency department in the US. The news have stated that there has been an increase by about 3.5% of patients presenting with upper GI bleeding at the emergency department in the US. The good news is that even though the incidence is rising, but the outcomes are actually looking better. The need for endoscopy is less by about 35%, and the transfusions need is also less by about almost 40%. Patients were able to discharge without the need for admission, and the death rate is also decreased. So is this really a problem in the US? No, I don't think so, because with the widespread use of antiplatelets and anticoagulants, I think we're going to see this kind of problem worldwide. And over the past couple of years, we see that there have been a few management guidelines on upper GI bleeding published. For example, just last year alone, the American College of Gastro had published clinical guidelines for managing upper GI bleeding. The same year, ESGE also updated the management guideline for non-variceal bleeding. Bavena 7, focusing on portal hypertension and variceal bleeding, was also published last year. And just earlier this year, the ESGE also published management of esophageal variceal bleeding. So as you can see that the professional organizations have been updating the management of upper GI bleeding every few years now. And if we really break down the guidelines, what we will see is that all the guidelines address the management before endoscopy, during endoscopy, and post-endoscopy. This holds true across all the guidelines. But if you look at the guidelines carefully, what you will see is that there might be a slight change in pre-endoscopic and post-endoscopic management. But really, I think what's really the main thing here that has been changing over the past few years is the endoscopic therapy technique. For example, back a few years ago, when the Asia Pacific and International Consensus Group published the guidelines, the endoscopic therapy that we have touched on was mainly the conventional therapy, which is a dual therapy, is a combination of epinephrine injection and coagulation, or you may choose to use mechanical technique like endoclip. But last year, both ACG and ESGE have brought up new techniques, including hemospray, over-the-scope clip, or the coag forceps or monopolar soft coagulation. But because the data were not as strong, so the guidelines basically say that they suggested using these novel techniques for either rescue therapy or adjunct therapy. When all else fails, then you can think about using this. As far as the Doppler endoscopic probe, which is another new technique, that has not been recommended by any guidelines. So ever since last year, what's been happening in terms of the research. I'm showing you this video showing a conventional endoscopic therapy using dual therapy. This is a combination of adrenaline injection and thermal therapy as a treatment of adherent clots. So here we are injecting epinephrine 4 quadrants to take care of the bleeding vessel underneath this clot. And then we remove this clot to expose the non-visible bleeding vessels. And after that, we can actually use a GoPro to take care of the bleeding vessel underneath. But what's really emerging these days, so the emerging endoscopic techniques include hemostatic powder, different brands, over-the-scope clip, monopolar hemostatic forceps with soft coagulation or coag grasper. Some really new technologies include Doppler endoscopic probe, US-guided vascular therapy, and endoscopic suturing device. For my talk today, I would only focus on these 3 novel therapies because they have the best data that we can talk about. The rest 3 are really emerging, but I think we're gonna have to wait for a little while to see a really strong, solid evidence to adapt this into our routine use. I'm gonna start off with the hemospray or hemostatic powder. This is an example of how we use a hemostatic powder. This is not a peptic ulcer bleeding, but this is a post-sphincterotomy bleeding, but the concept is pretty much the same. So when you see the active bleeding site, you can actually spray the hemostatic powder right at the bleeding lesion. So this is how we use it. So really, what is already known about hemostatic powder? This was up until last year. So we know that the hemostatic powder is excellent in terms of achieving success rate of 95%. And it can be used as a combination therapy, or it can be used as a rescue therapy. However, the residency time of the powder on the lesion is about 12 to 24 hours. Therefore, the combination with other modality, either at the same setting or at second look endoscopy, may be needed. The rebleeding rate at day 3 and day 7 ranges from 12 to 25% for high-risk lesions, so that's pretty high. So it's actually a good modality for temporizing or rescuing the lesions when everything else fails. And it can be used in active bleeding as well. The cost can be very expensive though in many countries. So that's what we have known about the hemostatic powder. But what's really new? So we always thought that hemostatic powder should be an adjunct therapy or rescue therapy. But just this year, there is a study that was just published assessing the role of hemostatic powder as primary hemostatic method or monotherapy. And this study was done by the Hong Kong group. Professor Shan is also a co-author in this paper. This very important study assessing the hemostatic powder as primary method for treating non-variceal upper GI bleeding. This is a randomized controlled trial assessing or comparing the hemostatic powder, which is TC325, versus standard treatment. They recruited a total of over 200 patients randomized into each arm. And the primary outcome is to look at the ability to control the bleeding within 30 days. And as you can see here, that the hemostatic powder is not inferior to standard treatment as primary modality. Having said that, I think this paper got a very interesting editorial by Alan Barkan, who is also a very dominant figure in the field of upper GI bleeding. And this editorial, Alan pointed out very important points, including the patient cohort in this study is a mixed population between peptic ulcer bleeding and tumor bleeding. In fact, almost 30% of patients randomized into the TC325 arm had tumor bleeding, and that might somehow lead to procedural bias. And that's why we may see some differences. And also the immediate hemostatic rate in the standard treatment group is relatively low. So I think, it's still a very important study. This study is not easy to do. I think what we can take away from this study is that the hemostatic powder is very effective, and it can be used as a monotherapy in both peptic ulcer bleeding and tumor bleeding. However, for peptic ulcer bleeding, high risk, we really have to keep a close eye on that particular patient and watch for rebleeding. So I think we're gonna hopefully see more of a RCT of this similar scenario with a more more of the peptic ulcer bleeding patients rather than a mixed population. So moving on to over-the-scope clip. So what we know about over-the-scope clip over the past few years is that we learned from the STING study, which was published in 2018, that the over-the-scope clip can be used for rebleeding peptic ulcers. We also learned from Jensen's group that over-the-scope clip can be used as initial treatment for severe non-variceal upper GI bleeding. It decreases the rebleeding at 30 days significantly. But what we just have come to know is that there has been a huge randomized control trial assessing the ability of over-the-scope clip versus standard treatment in STING-2 study, and they looked into whether the over-the-scope clips can be used as primary modality for non-variceal bleeding. So they included 100 patients randomized into standard group and over-the-scope clip group. They followed the patients, and at the end, about 50 patients in each arm were analyzed. As you can see here, that the clinical success in the over-the-scope clip was better significantly compared to the standard group. The volume of epi injections is also less, obviously, because if you use the over-the-scope clip, you might not need to inject the lesion with anything at all. The persistent bleeding, meaning hemostasis at the end of the index endoscopic procedure, is also better in the over-the-scope clip. So I think that with that data, we learn more that over-the-scope clip can be used as primary method. So really what the study adds is that if you have the proper training in experienced hands, primary over-the-scope clip therapy appears to be superior to endoscopic standard treatment with clips for selected cases of non-variceal upper GI bleeding. So here is very important. When you read all these studies, one thing that you see is that many of these studies are being performed by very experienced endoscopists, number one. Number two, the patient cohort can be very specific or can be very broad. Like the TC325 study, they put together patients with peptic ulcer bleeding and tumor bleeding. But for this particular study, it's only peptic ulcer bleeding patients, but the endoscopists were very well trained and well experienced. So I think, the bottom line here is that all these techniques are good, but you have to practice and learn how to use it and use it with the correct group of patients. Now, here is another study, which is a meta-analysis assessing the efficacy of over-the-scope clip as a primary method compared to standard treatment. As you can see here, that the rebleeding rate at 7 and 30 days was better with the over-the-scope clip, as demonstrated by this plot here. Now, so here is an example of case that we use over-the-scope clip. This is a very a refractory peptic ulcer bleeding case with a minute perforation here. So we thought this is a good candidate for over-the-scope clip. We treated this patient with the over-the-scope clip, and the patient did well. Moving on to the last modality that I want to mention today, which is a monopolar hemostatic forceps with soft coagulation. There's been nothing really new in terms of data. The most recent study was published in 2019, but I just wanted to show you this study because I think it may be helpful in many of you who have the coag grasper in your unit. So the coag grasper can be used to stop bleeding for small vessels, less than 2 millimeter, a larger vessel, more than 2 millimeters. The technique may be a little bit different. For the small vessel, you can actually grab the bleeding vessel and burn it. But for the larger vessel, you might need to inject epinephrine around the visible vessel, and then you coax around the visible vessel 4 quadrant, and then you hit the visible vessel at the end. So here's the data showing that the coag grasper is more superior to hemoclip in terms of initial hemostasis and rebleeding rate and hospital stay, as well as the procedure time. Now, just to compare to you the pros and cons of these different techniques, obviously, over-the-scope clip, hemostatic powder, and the monopolar hemostatic forceps, these are here to stay. So if you're not familiar with these devices, I think you better get used to it, learn how to use it. The good thing about the over-the-scope clip is that it allows full thickness closure, is very effective. It can be used as a primary method or a rescue therapy. The difficult thing about this is that sometimes it's very difficult to use, especially if the lesion is very fibrotic or in a difficult location, like the bulb, posterior wall of the bulb, and it may create some rare severe complications like intestinal obstructions or position deviations. Hemostatic powder is very, very easy to use. Everyone should be able to use it. The disadvantage is that it may have a high rebleeding rate, delay rebleeding rate, and the cost is also quite expensive in many areas. The coag grasper, I think this is very easy to use. It's very effective for small vessels. It's readily available, but the question remains about the efficacy in large vessels. And the other modalities right now, they're not ready for prime time yet, so we have to stay tuned for their roles in the future. Besides from endoscopic techniques, what else is new over the past year? Timing of endoscopy. This is something that we've been talking about. Should we do it early, before 6 hours, or should we delay it? What's the best timing? Again, the Hong Kong group with Professor Shan as a co-author published earlier this year in Gut. They recruited over 6,000 patients across Hong Kong and divided them into 3 groups. The first group is urgent group, meaning the endoscopy was performed within less than 6 hours. And the second group is early group, meaning the endoscopy was done between 6 to 24 hours. And the late group defined as endoscopy was done after 24 hours. What they've shown is that patients who had endoscopy performed within 6 to 24 hours performed the best in terms of 30-day mortalities and 30-day repeat therapeutic endoscopy. So remember, too early is not good. Too late is also not good. So adequate resuscitation is key. So spend those 6 hours resuscitating your patient adequately. So before I finish, I'd like to give you some tips, especially if we have first-year fellows watching the program. I think risk stratification is key. I haven't mentioned much about risk stratification here in this talk because it hasn't been much of anything new. There are some studies assessing or coming up with a death score that we can use adjunct to the Blatchford score, which we always use. But again, risk stratification, define your patient whether or not they have high or low risk, so you can manage them accordingly. Number 2, use a restrictive transfusion approach. Don't over-transfuse your patient. This is true for both varicose and non-varicose. Keep the hemoglobin at about 7, 8. The caveat about this is that if you have a patient with active coronary syndrome, you don't want to let them become anemic for so long. So this, when I'm talking about stable patients in terms of coronary artery disease. The timing, we talked about it, 6 to 24 hours seems to be a magic number. We should use dual endoscopic therapy for active spurting, oozing, non-bleeding visible vessel adherent clot, which is considered high-risk lesions. We should try to apply new methods for difficult cases, for example, hemostatic powder and over-the-scope clip. It's very important to define those difficult cases. So patient characteristic and also characteristic is key here. High dose IV PPI after endoscopic therapy for high-risk lesions, this is also key. The pre-endoscopic PPI is controversial. You may or may not give it before endoscopy, but after endoscopy, if you identify high-risk lesion, then PPI high dose is key. Repeat EGD if rebleeds. You have second chance. And think about alternative method like arterial embolization. If your patients have recurrent bleeding or difficult lesions, that's going to depend on patient characteristics. Finally, I'd like to thank you very much for your attention, and I'll be happy to answer the questions at the end of the sessions. With that, I would like to go back to my moderator podium and introduce our next speaker. I hope Professor Rome is here. Professor Rome, are you here?
Yes, I am, Ajahn Nonthalee.
Yeah, great to see you here.
Can you hear me all right?
I can hear you very well. And next, I have the pleasure of introducing our next speaker, Professor Rome Jutabha. He is currently a professor of clinical medicine at Keck School of Medicine of University of Southern California. And he's the director of clinical outreach and development, Keck Hospital of USC. His field of specialization is in the area of diagnostic and therapeutic endoscopy. Dr. Jutabha oversees a preeminent research group in the United States and Thailand that develops innovative digital health solutions and minimally invasive and remote diagnostic techniques for the evaluation and treatment of various gastrointestinal diseases. In addition, he's involved in various projects related to globalization of healthcare. He holds memberships and leadership positions in numerous professional organizations. It's really my pleasure to introduce Professor Jutabha to give a talk entitled Capsule Endoscopy, Current Roles and Future Expectation. Please.
Yes, thank you very much, Ajahn Nonthalee, for that very kind introduction. Also, I'd like to thank the meeting organizers for inviting me to give this presentation. I do apologize that I'm not able to attend in person, though I'm just very backed up with trying to catch up with COVID cancellation procedures. One of the silver linings of COVID was that a lot of what I was interested in doing was not getting a lot of traction before COVID. With the advent of COVID and the restrictions on procedures and travel, telemedicine became quite front and center, which overnight became widely adopted throughout the United States and was also reimbursed by insurance companies. So my talk will be focused more on small bowel capsule endoscopy. I will make some mention about upper GI capsule as well as colon capsule, but the data is relatively limited in comparison. So it will be focused primarily on small bowel. I'll first start off with giving you a historical perspective of this technology. I was first introduced in the US with FDA approval back in 2001 of the Given Imaging M2A capsule, and that was indicated for obscure GI bleeding. It was initially called M2A, standing for mouth to anus, because it could image the entire GI tract from the mouth to the anus as it traveled through, limited only by battery life. Then I'll talk about the current indications for capsule endoscopy, as well as future indications. This is in the setting of diagnostic for obscure GI bleeding, or inflammatory bowel disease, unexplained abdominal pain, diarrhea, etc. And then in the screening indication for patients with chronic GERD, evaluating for Barrett's esophagus, looking for esophageal varices in patients with advanced liver disease, colorectal polyp and cancer screening using the PillCam colon capsule, or follow-up of polyposis syndromes. And then in the future, as the technology evolves, there will be a therapeutic potential from these capsules as well. Then I'll end off my presentation talking about future developments in the areas of hardware, software, and telecommunication networking advances. On the hardware side, I'll present some slides about multifunctional capsules that have dual or multi-modalities, including imaging, biosensors, drug delivery, hemostasis, as well as fluid and tissue sampling. AI image analysis is also another important area of development. As those of you who do capsule endoscopy, I know that it does acquire quite large amounts of recorded images, which then need to be reviewed manually by physicians. So with the help of machine learning and deep learning, AI has potential for making this process more efficient and more effective. And then finally, I'll talk a little bit about our TeleGI initiative here at Keck USC, in which we got funding for a telemedicine-based approach for point-of-service diagnostic imaging for patients with GI disorders utilizing capsule endoscopy. And the framework is very similar to what is done in radiology with mobile ultrasounds, mobile mammography, and with centralized reading. So this is a schematic of the timeline of endoscopy starting from the early 1800s with rigid endoscopy, advancing through rapidly with semi-flexible and fully flexible endoscopes. And then with the advent of small bowel endoscopes, the sonde endoscope, push enteroscopy by Blair Lewis, who promoted that technique in the US. And then with the advent of capsule endoscopy in 2000, there was a big explosion of new endoscopic technologies and devices using double balloon enteroscopy, single balloon enteroscopy, spiral enteroscopy for follow-up of capsule findings. So this slide is just to show a bit of a disconnect between what we as gastroenterologists want to do and what patients would actually prefer. Now here on the left side, you have a very eager GI fellow who wants to do deep enteroscopy, but the patient's not very happy to be having that procedure. They would much rather have the capsule endoscopy. And so part of the limitations of why this technology has not been widely adopted relates in part to both physician preference as well as patient preference. So for those of you who are old enough to have seen this movie, it was called The Fantastic Voyage, where they shrunk the people, injected them into the bloodstream in a submarine, and then they traveled to the brain to treat a brain tumor. Now, our technology has not advanced that far yet, but here in 2001, the initial capsules here, let's see if I can get the pointer. Can you see my pointer here?
Yes, we do.
Okay, so here, this is the original capsule manufacturer, Given Imaging, which is now Medtronic. They came up with the small bowel capsule, which has one camera on it and would record for about 10 to 12 hours, imaging primarily a small bowel. Then they developed the PillCam colon with two cameras on either side, which was intended to evaluate the esophagus and upper GI tract. Unfortunately, this company is no longer manufacturing or supporting this platform because the uptake of the technology from gastroenterologists has been very slow. Another technology that they developed was PillCam colon, which is also dual-sided. It does hibernate as it travels to the small bowel to conserve battery life, and then images within the colon looking for polyps or other pathology. Shortly thereafter, Olympus also came up with their own capsule device. And this was a charge couple device. It was very good resolution, but also Olympus recently has made the decision to back off of this small bowel capsule market. And then you can see here, there are capsules from China. This is Taiwanese, Chinese, and US based. Miracam is Korean based, and this is a CapsoVision capsule. This one is a little bit unique compared to the other ones, which has a radio transmitter that sends a RF signal to a data recorder, and the images are stored on that data recorder and then downloaded. With the CapsoVision capsule, this is actually stored on board and a chip, so that you don't need a sensor array, you don't need data recorders. The patient swallows the capsule and then retrieves the capsule, and the data is then downloaded from the capsule. The Philips iPill camera was a prototype for drug delivery. So the FDA approved indications here in the United States for small bowel capsule endoscopy is primarily obscure GI bleeding. It's also approved for small bowel Crohn's disease for surveillance of disease activity, as well as for suspected small bowel tumor. Other indications in which small bowel capsule endoscopy is performed, though not FDA approved, is for unexplained diarrhea, unexplained abdominal pain, as well as acute upper GI and lower GI bleeding. And we have several studies ongoing here in the US looking at capsule endoscopy for this indication. So which patients should you consider small bowel capsule endoscopy? Those who present with obscure GI bleeding, that is after a negative upper endoscopy, negative colonoscopy, that should be followed up by a capsule endoscopy. The important point here is the diagnostic yield. If it's acute bleeding and overt, meaning that you see overt blood, versus in those patients who have chronic bleeding, iron deficiency anemia, and occult bleeding, in which the diagnostic yield is much less. So the point that's important is that if you have a patient who presents to the ED with acute bleeding following negative upper endoscopy, negative colonoscopy, you should try to administer capsule endoscopy right away. Our studies are looking at the converse of that. Rather than waiting to have a negative upper, negative colon, we would administer the capsule as an initial diagnostic test while the patient is being evaluated and resuscitated and prepped for their endoscopic procedures. And some of our preliminary data show that this has very high diagnostic yield and will actually help us target whether to do upper or lower procedure first. Patients with diarrhea and malabsorption with various diseases that are listed there have also been reported for the capsule endoscopy. Patients with abdominal pain, we do find quite a lot of pathology in these patients, either inflammatory lesions, ulcerative lesions, mass lesions, as well as patients who have intraluminal narrowing and intermittent obstruction. So patients with pain and obstructive symptoms, you have to be very cautious due to the risk of capsule retention, as well as small bowel obstruction. And these patients should probably undergo patency capsule prior to this study. So what is the utility of capsule endoscopy for obscure GI bleeding? First, we want to localize the site of bleeding. Is it within the proximal, mid, or distal small bowel? If it's in the proximal, then we would do deep endoscopy in the antegrade fashion. And if it's distal in the ileum, we would go retrograde initially. Oftentimes, we're able to identify the specific source of bleeding, that is a specific mass, ulcerative lesion, or vascular ectasia. We also can risk stratify patients into whether they need urgent endoscopic intervention or it can be done electively on an outpatient basis. So if you see non-bleeding AVMs, these can be discharged and done as an outpatient, versus those with active bleeding from the small bowel should be admitted and then undergo deep enteroscopy or other endoscopic treatments, angiographic embolization, or surgical resection. There are many countless studies showing that capsule endoscopy is the gold standard for imaging the small bowel for obscure GI bleeding. And there are just a few references listed there on the bottom, demonstrating that capsule endoscopy has established safety, high sensitivity and specificity for obscure GI bleeding. It has very high diagnostic yield for identifying the specific source of GI bleeding, and it has proven efficacy as compared to other diagnostic modalities. Now, just briefly mentioning about PillCam colon for polyp detection. This is a chart summarizing various studies using PillCam colon 1 and PillCam colon 2, looking for polyps greater than or equal to 6 millimeters in size or greater than 3 polyps. And you can see here for those studies here using capsule endoscopy, the PillCam 1 generation, you had relatively modest to moderate sensitivity as well as specificity. With a higher resolution PillCam colon 2 generation, it has higher sensitivity and specificity for detecting polyps. Now, it is FDA approved here in the US. Most insurance companies are starting to cover for this procedure. But as you can imagine, most gastroenterologists do not see a big benefit of doing capsule endoscopy as a routine screening test. Right now, it's approved primarily for patients who've either failed standard colonoscopy or who have comorbidities that would be contraindications for standard colonoscopy, or those who've undergone colonoscopy and had an incomplete examination. This slide is just a list of some of the contraindications to capsule endoscopy. Those patients with swallowing disorders or who have narrowings that would result in capsule retention or bowel obstruction. There's a relative contraindication for pacemaker or defibrillators, though there have been no reports of any inadvertent triggering of defibrillators caused by capsule endoscopy. So anyone undergoing an MRI procedure or MRE should not have a capsule endoscopy prior to this examination for obvious reasons. So what are the factors that limit capsule endoscopy utilization here in the United States? Probably the primary reason is that there's perceived limited clinical utility with capsule endoscopy as compared to standard endoscopy or colonoscopy, and that's unlikely to change in the minds of most of my GI colleagues in the US. The cost is always brought up, is that it's about $500 to $600 per capsule, which is disposable, one-time use. But I would point out that their upfront cost for any fixed capital is relatively modest. The workstations now for a PillCam workstation is very affordable, about $15,000 to $20,000. With competition now, I foresee that the cost of each capsule will decline as utilization increases. Another limitation of capsule endoscopy is that it's dependent on peristalsis for movement through the GI tract. Now with the advent of magnetically controlled capsules, we can actually steer the capsules back and forth, side to side, up and down, but it's unlikely that you would get operators who'd be sitting there for the entire exam steering this capsule. So there are algorithms that are being worked on to do automatic steering, in particular within the stomach, so that you can do a full endoscopic examination EGD examination automatically. Currently, there is no therapeutic potential with these capsules, but there are many companies working on different hemostatic type of electrocoagulation, drug delivery, et cetera, for hemostasis. Another one is limited number of facilities who have this equipment, and there's also limitations on the people who are available to read these capsule recordings. And probably from an end user perspective, the most challenging one is having to sit and review these long recordings. On average, we spend anywhere from 30 to 60 minutes per case looking for GI bleeding. If it's overt, we can find it very quickly in less than 5 minutes. However, if we're looking for isolated AVMs that may or may not be bleeding, this oftentimes takes quite a lot of time and effort to identify any significant pathology. And so some of the innovative solutions that are being developed by our group and others are looking at models that other subspecialties have done successfully. Primarily, the radiologists have been very pioneering in teleradiology, in which they have mobile devices and centralized reading and AI assistance for overreading of X-rays. So this is the grant that I alluded to. This is funded by the Federal Communications Commission. It was a grant that was part of the COVID Relief Challenge, in which patients who had delays in getting endoscopic procedures for upper screening as well as lower screening for colorectal polyps and cancer, we came up with a proposal to use capsule endoscopy as a screening modality. And the novel approach was, rather than the patient coming to us, we would send the equipment to the patient or to the patient's primary care physician in remote locations. So as you can see there, the smart box, which is a fully contained device that has a data recorder, the capsule, and a Wi-Fi enabled MiFi transmitter, so that the patient can then talk with the referring physicians, be walked through by the technicians on how to administer the capsule, how to ingest it, and then how to download the data to us. And this box is compatible with various manufacturers. It's our hope that once we have proof of concept here locally, that we'll then expand to other regions around the world. We have an independent group that is also doing a similar project in the UK, using the PillCam colon as a primary screening tool due to their backlogs. In Thailand, we've spoken with the National Broadcasting and Telecommunications Commission about doing a very similar type of study in Thailand and perhaps expanding to Southeast Asia. So if there are people here in the audience that are interested in becoming a site for this study, please contact me with further details. So now I'll shift to sort of what I alluded to before about AI. Now, if the lesion is very evident where there's lots of blood within the small bowel, we can usually find it using just the SBI indicator or just by doing a quick scroll through the recording. And you can see here, if we don't find it right away, like looking at this morass, where is the bleeding? Where is Waldo? Now, you would be spending a lot of time and be getting very tired and falling asleep here. And so this is where I believe that AI algorithms will have the biggest impact. And this is just one study looking at AI for image analysis of capsule endoscopy images that can find ulcers, erosions, vascular ectasias, as well as tumors. And so this has great potential for the future. And this is also evidenced by the number of companies that are entering into the AI space for healthcare. And we're just one small segment in the medical imaging and diagnostic realm here. And those of you who have used AI for colonoscopy know about GI Genius, about other companies that have also developed algorithms primarily for colon polyp detection. So here are some of the future capsule technologies on the hardware side, in which there will be multifunctional capsules where we can control and steer the capsule through the GI tract. When we find a pathology, the capsule will deploy an anchoring device to fix it in place so that they can then perform hemostasis and then stay in place looking for rebleeding. This is a new device here in the United States that has recently been approved for clinical use. Those of you in Asia and in Europe may have seen this much earlier in clinical practice, where the magnetically controlled steerable capsule can be used manually as well as automatically to do screening examination of the upper GI tract. I would envision that this will also have application to the small bowel as colonoscopy as the technology advances. So here are my take-home messages for a capsule endoscopy. As I think most of us here in the room would agree that small bowel capsule endoscopy is the preferred diagnostic test for obscure GI bleeding for the various reasons I mentioned previously. Upper GI and colon capsule endoscopy are potentially useful screening as well as diagnostic tools to supplement, not to replace, standard endoscopy and colonoscopy. And that future developments will focus on multifunctional, magnetically controlled capsules. AI-assisted image analysis will increase the efficiency for capsule interpretations and reporting. And then finally, the telenetworking of these images will increase utilization through telemedicine encounters in remote areas, through point-of-service capsule ingestions at off-site locations, and then utilizing cloud-based capsule endoscopy data storage, transfer, analysis, and reporting platforms. Thank you very much for your attention.
Thank you so much, Rome. All right, so I think this is the time for Q&As. I have a lot of questions lined up, but I think that I'm going to pick about 3 questions, one for each of us. I'd like to invite Professor Shan to come up on the stage, and as he is walking up here, I would ask the questions. The first one goes to you. Well, I have lots of questions for you, but I'm going to pick this one. Any difference for managing upper midgut and lower GI bleeding in patients who have to continue anticoagulants, such as patients who's got metallic valve replacement?
For upper GI bleed, for patients with upper GI bleed who are on anticoagulant, we have various endoscopic treatment to stop the bleeding. Unfortunately, for midgut bleeding, we can't really stop the bleeding. So it's often a kind of dilemma for midgut and even lower GI bleed with anticoagulant. The dilemma we are facing is, number one, we don't have an effective treatment to stop the bleeding. Often the bleeding site is obscure and even multiple. So the question we want to ask ourselves is, what is the thrombotic versus the bleeding risk? If the thrombotic risk is substantially higher than the bleeding risk, we have to, number one, continue the anticoagulant. We have to choose the drug with the least bleeding tendency, which could be either apixaban or warfarin. But in case of metallic valve replacement, we have no choice but to continue with warfarin. Number 3, we have to be very aggressive in trying to identify the source of bleeding, including capsule or various other modalities such as balloon endoscopy. On the other hand, if the thrombotic risk is considered to be low, then we have to discuss with the cardiologist whether we can really stop the drug and deal with the bleeding and try to avoid recurrent bleeding. So it has to be individualized.
Yeah. So sometimes it's kind of a difficult situation to manage whether to stop the anticoagulants or to continue. I think the risk and benefits is a key here. So Professor Rome, you and I kind of got similar questions about AI-assisted diagnosis and treatment of GI bleeding. So I'm going to ask you first, is there any data assessing or comparing AI-assisted capsule endoscopy in detecting small bowel lesions compared to trainees' performance?
No, not head-to-head comparison, but looking at the AI literature, that they do have certainly faster image analysis. It takes much less time for, the computer to review 70,000 images than a human being, and it also has higher detection rates as compared to human beings. I think it really centers more around specificity. The early algorithms were not very specific, so it picked up lots of extraneous lesions. But with deep learning, machine learning, and better annotations of large data sets, that this will also improve over time.
Okay, all right. And the last question is about AI technology. Is there any role of AI technology in the near future for upper GI bleeding management? So our group is running a couple of studies using, number one, machine learning for risk stratification of patients presenting with upper GI bleeding. By far, the data seem promising, but it's not perfect yet. There is a publication by Lauren Lane Group about the machine learning for risk stratification of upper GI bleeding patients, and that seems to be very promising. And we're also running a study using AI-assisted for risk classification in patients presenting with peptic ulcer bleeding. We are using that as a tool to help the fellows to identify or classify the peptic ulcer lesions. And I think that the utility of AI, as Professor Rome said, I think it's really there. We just have to fine tune it a little bit more. And I hope that maybe next year, if we come back again, we will see more of the AI data for both upper GI and small bowel. There are a few questions. I will, if possible, I'll answer the questions through the online, but because the time is up, so I would like to conclude this session. And before I conclude, I would like to thank our speakers, Professor Shan and Professor Jutabha, for being here with us today. I hope you guys had a wonderful session and learned a lot from these two speakers. With that, I'd like to conclude this session. Thank you.
Thank you.
Thank you.
Yes, thank you very much.
Bye. Yeah.